Okay, so let's talk about overview of hemolytic anemia. It's based on the what is written in the American Manual of Professional Edition. It's overview. It's not about a specific type of hemolytic anemia. So, hemolytic anemia is what is hemolysis? Hemolysis is the destruction, let's say, of the red blood cells before it should be destructed. I mean, red blood cells usually lives around 120 days. Then it, it should die in the reticuloendothelial system, in the bone marrow, in the liver, or in the spleen. Those are the places where it should die. The After the red blood cells die, the hemoglobin is processed to bilirubin in the end, and conjugated in the liver, and etc. etc. Now, in hemolysis, there is a death of the red blood cell before it should have died, before the 120 days elapsed, and this is hemolysis. Now, the hemolysis can be of some types. It can be extrinsic problems of the red blood cells and intrinsic problems of the red blood cells. When we talk about intrinsic problems, usually those are problems in the membrane of the red blood cells, in the shape of the red blood cells, which cause it to be less able to uh, get throughout the spleen especially, and because of it, it dies there. And we're talking about spherocytosis, ellipsocytosis, and things like this. Those are the intrinsic problems in the red blood cells. Now, the extrinsic problems, namely comes from outside the red blood cells, are diverse. For example, G6PD, glucose 6 phosphate dehydrogenase, is a problem with the agglutination and oxidation of the red blood cells, which cause it to die preterm. Uh, Immunological factors like autoimmune hemolytic anemia, cold agglutination, warm autoimmune hemolytic anemia are antibodies that di- direct the red blood cells and cause them to die in the spleen and the reticuloendothelial system preterm. Other things are like medications that can cause hemolytic anemia, um, situation like mechanical valves that can cause the red blood cells to be damaged, and damaged red blood cells are prone to get filtered in the spleen even before it times to die, namely intravascular hemolysis, mechanical intravascular hemolysis. Um, what else can cause extrinsic factors? Other mechanical factors are like TTP, DIC, HUS. Those are the microangiopathic hemolytic anemias that can cause also damage to the red blood cells, schistocytes, and death of the red blood cells. Okay, so there are intrinsic factor, extrinsic factor. There is intravascular hemolysis, where the red blood cells die in the vascular system, and there is extravascular hemolysis, where the red blood cells die in the reticuloendothelial system, like in the spleen mainly. Uh, Not forgetting hypersplenism, splenomegaly, which cause the spleen to uh, filter even normal red blood cells. The liver should, with the reticuloendothelial system, with the macrophages in it, to filter the red blood cells that are damaged, that should be filtered. But when the spleen is enlarged, where there is hypersplenism and splenomegaly, the spleen can take even normal red blood cells and filter them and cause extravascular hemolysis. Now, to differentiate, no, let's make it more clear. There is extrinsic factors and intrinsic factors for the hemolysis, and there is extravascular hemolysis and intravascular hemolysis. Those are two things. When we talk about extrinsic factors, are like medications, immunological factors, uh, mechanical factors, and intrinsic factors of the red blood cells are changes of the shape of the red blood cells like spherocytosis, erythrocytosis, spherocytosis, elliptocytosis, and things like this. Now, on the other hand, there is the place where the hemolysis occurs. It can be in the blood vessels, which is called intravascular hemolysis, and there is hemolysis out of the blood vessels, which is called extravascular hemolysis. Okay. Now, when there is intravascular hemolysis, one of the very characteristic findings are schistocytes, which are fragmented and damaged red blood cells that can be seen in the peripheral blood smear. You can see blood cells, and some of them are like eaten or like damaged or like broken. Those are the schistocytes that are they characterize the intravascular hemolysis. Okay, so extrinsic factor, intrinsic factor, intravascular hemolysis, extravascular hemolysis. Okay, now remember this: when a blood cell die, the hemoglobin turns eventually to unconjugated bilirubin. This unconjugated bilirubin should go to the liver, be conjugated there, and move to the bile uh, and go out of the body throughout the bile. Now, when there is too much of unconjugated bilirubin, which can happen if the hemolysis is uncompensated, namely the liver cannot, no, this is not being compensated. Let's say the liver cannot compensate for the, or let's say the liver don't have enough enzymatic power or don't not able to stand the large amount of unconjugated bilirubin in order to conjugate all this bilirubin. So, when there is such a high level of unconjugated bilirubin, the bilirubin can cause the skin to yellowish, especially the sclera and the frenulum under the tongue. Note that the first place that jaundice is seen, which is caused by the unconjugated high level of unconjugated bilirubin, is the frenulum and the sclera. So, sclera icterus is the name for the jaundice seen in the sclera of patients with high level of bilirubin. Now, it's not pathognomonic only in the hemolytic anemias where the bilirubin is elevated. Also, other pathologies like many pathologies of the liver, like cirrhosis, like hepatitis, like I don't know, a gallbladder stone that cause a blockage in the biliary tree, all the things that cause an elevation of the level of conjugated or unconjugated bilirubin will cause eventually jaundice. Now, hemolysis, which cause breakdown of red blood cells, which cause breakdown of hemoglobin, which cause elevation of unconjugated bilirubin, can also cause jaundice as one of the signs of hemolytic anemias. There are also other signs of hemolytic anemias. Uh, the risk for thrombosis from some of them is elevated, like in paroxysmal nocturnal hemoglobinuria, when the PIG-A gene is defected, a somatic defect, namely it's not congenital but acquired. In PNH, paroxysmal nocturnal hemoglobinuria, the PIG-A gene is defected, is damaged, is mutated, how whatever you call it, and the CD something is pathological, the GIF, IGIF or something like this, pathological, and the complement system can damage the red blood cells in the vascular system, so it is intravascular hemolysis and is one of the things that can cause the elevation of unconjugated bilirubin and hemoglobin in the urine. Now, when hemoglobin gets to the urine, it can cause a red cola-like urine, like can be seen in paroxysmal nocturnal hemoglobinuria, where in the morning their urine is like dark. And this is because the myoglobin can get to the urine and get excreted throughout the urine and colored urine darker. Okay, so in hemolytic anemia, oh, just a moment. So in hemolytic anemia, we would expect to see anemia. Now, the anemia can be compensated or uncompensated. And when I say compensated, is the question: does the bone marrow can compensate for the loss of hemoglobin by the hemolysis? Now, the bone marrow can create many red blood cells, cause the reticulocyte count to be elevated, namely cause reticulocytosis, and compensate for the loss of hemoglobin by the hemolytic anemia. When this is what happens, it is and the anemia is compensated, is called compensated hemolytic anemia. But when there is a other problem with the bone marrow, or the bone marrow can, let's say, keep up with the loss of hemoglobin, so even even reticulocytopenia can happen. Now, let's say that there is a problem in the bone marrow, and the bone marrow can't create reticulocytes. So we can see, in one hand, hemolytic anemia, and in the other hand, reticulocytopenia, which we won't expect in just hemolytic anemia. We would expect that the bone marrow will compensate for the loss of hemoglobin with elevation, with erythropoiesis, which will cause elevation of young shapes of red blood cells, namely reticulocytes. So, if the are low, it's not what we would expect to see. So there is reticulocytopenia. So the hemolytic anemia is uncompensated hemolytic anemia. And this can be seen when there are other, aside for the hemolytic anemia, there are other problems in the bone marrow. I don't know, immunodysplasia or anything that can cause iron deficiency or whatever, that cause the bone marrow not to compensate for the hemolytic anemia. So in hemolytic anemia, what we can see anemia, signs and symptoms, pallor, weakness, fatigue, everything you can see with anemia. We can see jaundice, elevated bilirubin levels, unconjugated bilirubin. We can see sometimes dark urine. Also, we can see high levels of LDH, which is a lactate dehydrogenase, which is an enzyme, I think, in the red blood cells. Anyway, it's in the red blood cells, and when there is an hemolysis, the levels of LDH, one of the markers of hemolytic anemia, can be elevated. Now, remember that it is not just elevated in hemolytic anemias, it's not specific. In other diseases like lymphoma, LDH can also be elevated. So, bilirubin is elevated, LDH is elevated, hemoglobin is low, red blood cells is low, and usually the MCV is around normocytic. Uh, Now, haptoglobin is another protein that we would expect it to be low. And why? Haptoglobin, the idea or the purpose of the haptoglobin protein is to capture the free hemoglobin in the blood because of the hemolysis, and capture it and not let it go around as it wants, because hemoglobin can cause problems, I think oxidative problems, etc., etc. So haptoglobin should be connected to hemoglobin, and its levels should be reduced because it is connected to hemoglobin hemolytic anemia. Okay, so haptoglobin is low, anemia, elevated bilirubin, elevated LDH. Potassium can also be elevated because potassium is mainly inside the cell, but it's not a very distinctive characteristic. So let's not talk about potassium. Uh, Another test that we can do are the Coombs tests. There are two types of Coombs test: the direct Coombs test and the indirect Coombs test. Now, what's the difference? There are types of hemolytic anemias where there are antibodies against the red blood cells. This or these are types, those are types of hemolytic anemias which are the extrinsic types. There are outside factor which cause damage to the red blood cells or the red blood cells get lost because of it. So, in some of the types of hemolytic anemias, there are autoantibodies against the red blood cells or complement system which uh, connect to the red blood cells and cause it to be more prone to degradation in the spleen. Those are things like autoimmune hemolytic anemia, cold autoimmune hemolytic anemia, war antibody hemolytic anemia, autoimmune hemolytic anemia. There are Those are immune mediated hemolytic anemias where there are antibodies against the red blood cells. Now, they can be bound to the red blood cells, and then when we test it, when we take, let's say, antibodies against those antibodies that are connected to red blood cells with dye, let's say, we can see that the red blood cells have antibodies on them. This is called Coombs direct Coombs test or direct agglutinin test, which is positive. But sometimes there are antibodies in the plasma, in the serum, but not on the red blood cells. We can also check for red blood cells on the plasma which are not connected to red blood cells. This is called indirect agglutinin test or indirect Coombs test. It happens like in pregnancy where the mother is Rh minus and the fetus is Rh plus and the fetus blood is because of trauma or something gets into the mother blood and the mother's blood identify the fetus blood as forging because the mother blood don't recognize the Rh as positive, so it creates antibodies. Now the antibodies are not against the mother's blood. The antibodies are not against the mother's RBCs. So the antibodies are in the blood, in the plasma, but not on the RBCs of the mother. But if again the mother uh, exposed to the blood of, let's say, the fetus, which is Rh plus, it will attack it. It will attack it, and this can cause anemia in the fetus and what is called hydrops in the fetus. But we won't get into this. This is the idea of indirect Coombs test to identify antibodies which are against red blood cells in the serum, but not on the red blood cells of the patient, because it can be against other red blood cells from transfusions, from a baby that is Rh plus when the mother is Rh minus. This is the indirect Coombs, but the direct Coombs test, direct agglutinin test, it looks for antibodies on the patient's red blood cells. This is the difference, and it is quite important because Coombs test is quite common test, especially in pregnancy. So I talked a little bit about it. So it is another test we can use to identify antibodies on the patient's RBC or in the plasma of the patient. Okay. Now, treatment is treatment of the cause if we can identify it. Let's say because of an infection, which can cause also malaria, for example, can get into the red blood cells and cause destruction of red blood cells. This is we can treat malaria. This is the treatment of the cause of hemolytic anemia in this patient, in the patients with malaria. So, if we can identify and treat the cause, this is important. We also can, uh, if there is low hemoglobin, we can treat with transfusion if needed. Um, okay, so if there are, let's say, cold antibodies, the patient should avoid cold temperature and etc. So, look for the underlying cause, and if you can find it and treat it, treat it. And for especially for low hemoglobin, we can think about transfusions and I won't get into each type of hemolytic anemia. What is the treatment? This is not the idea of overview of hemolytic anemias. It's just a presentation, intro to hemolytic anemias. So this is the idea of hemolytic anemias in as overview. I'm not sure I talked about everything, but I wanted to give you a motivation or talk about it a little bit. So if I made any mistake, I'm sorry, and please correct me. And this is an overview about hemolytic anemia. Thank you very much, and that's it.